Many surgical techniques, like the use of air in the subretinal space to replace subretinal hemorrhage. Also, Dr. Mahmoud developed the first human autologous retinal transplant. Dr. Mahmoud introduced chandelier buckling in the USA, and he introduced the ILM retractable portal for the macular hole. Dr. Mahmoud is a member of many prestigious societies like the American Academy of Ophthalmology, the ARVO, the American Society of Retinal Specialists, Joliet Bean Club, Macula Society, and Retina Society. Dr. Mahmoud received many prizes, specialists, and also received Presidential Honor Award from the American Society of Retinal Specialists. Also, he received the Achievement Award from the American Academy of Ophthalmology, Robert Machner Award from Duke Eye Center, and Golden Globe Award for resident from the Duke Eye Center. Dr. Mahmoud, in 2009, were chosen one of the list of the best doctors in America. Please welcome Dr. Tamer Mahmoud.
Thank you very much, Dr. Bushusha. It's a pleasure to be here among so many friends that I learned from, and I shared cases over the years. And my main topic today is about macular holes, and it's very exciting to talk about this topic that we all share many cases from, and there has been significant evolution over the last few years. And we can just imagine that more than 30 value of partial vitrectomy in macular holes, a lot of surgeons were against them, asking them, why would you do partial vitrectomy for such a procedure? And even when they published their first series, imagine that the closure rate reported was only 58%. And those that closed, 73% gained 2 lines of vision. I think we came a long way for the last 30 years. And I can just show you the complexity of macular hole treatment represented by my personal algorithm that I use now, and how it's not only partial vitrectomy. I use all those modalities from partial vitrectomy to an ILM peel to different types of ILM flaps, and then ERT, amniotic, and so on. So we're going to discuss some of those so we can see where we were and where we came from and where we are nowadays. So initially, partial vitrectomy was the procedure of choice. This is even before OCT became available. That it was available in most clinics. We can describe more macular hole, see the traction, and vitrectomy can remove the anteroposterior traction. But then, in the beginning of the 2000s came dyes, like ICG dyes, and we can visualize ILM and we can peel it, and then it became the procedure of choice, so we can remove the tangential traction for a better anatomical and functional outcome. But when Yeji Navraska described ILM inversion for macular holes, but some were also discussing that, well, ILM EP is very successful. Why would you consider an ILM flap? Then Stanorism had more than 600 cases and showed ILM peel versus flaps. And then in regular macular holes, the outcome is about the same. But when you look at macular holes that are larger than 400 microns, or axial length more than 26, which is high myopia, then there is a significant difference in the outcome when you use an ILM flap versus just a peel. Grazia Pertini also showed the same in high myopic patients, with a 22 times more success with the ILM flap in those difficult to close holes. Then, back then, 10 years back almost, we described the first human autologous retinal transplant. And why did we come to that procedure because my first patient was a very high myopic lady that had multiple myopic whole retinal detachment with a macular hole. The ILM was completely peeled. So the only option was to try to get a free ILM flap, and we were not able because of the thin ILM in those cases. So we were able to get a neurosensory transplant or an ART, and we were excited that the hole closed. But what was really exciting, that gradually that retina thickened and started developing outer layers, and with co-localization with microperimetry, there was, as the vision increased, there was more increased sensitivity over the central retina. And since then, there has been an explosion of procedures for macular holes. Some of them were old concepts of procedures, and some of them were newer ones that were developed. From lens capsular flap to hydrodissection, which is an old procedure. Some surgeons thought that, I can still do a very wide ILM peel and a long-acting gas and they would work. But then there was also explosion of the type of ILM flaps that we can use, from an inverted to free flap to a retracting door and so on. And then the amniotic, the ART combined with choroidal transplant, and now combined amniotic and ART, and we're going to go through some of those. So since then, some of the groups around the world developed some of the refinement of the procedure to see how can we improve anatomic and functional successes. So we went back to some of the surgeons that adopted initially the technique, and we looked at 41 cases of refractory macular holes, and in 1/3 of those there was a significant improvement, more than 3 lines. And this was very exciting at this point, and complications were minimal. Then with Kazubaki Katamusolo, we looked at primary macular holes that are large, that are difficult to treat, and we had even more success in those cases because they were not very chronic holes with co-localization with microperimetry. This opened the door to the ART global study, and many of the surgeons are sitting here in the audience. We had 33 surgeons with 130 patients. 27% were primary, 58% refractory, and 15% the very difficult macular hole retinal detachment that 2/3 of those had surgery before. And as you can imagine, those are very large holes. It was exciting in that initial global experience that 89% closed with the ART and 95% of the macular hole retinal detachment. What do we expect morphologically? And we learned from the global study that usually ellipsoid zone recovers within about 3 months in those that had better outcomes. We also described a new finding called the alignment of the neurosensory layers, where initially you see the vertical line between the graft and the host macula, and gradually it fades away with alignment of those layers, and this was correlated with better outcomes. So 43% gained 3 lines of vision and 29% more than 5 lines of vision in that initial experience. It was also very exciting to see that 15 cases gained vision, 20/50 or better vision, which reflects that we can get macular function from peripheral retina. Now, it is important also to consider long-term outcomes. So what happened to that patient that I did 9 years back? As any patient with myopic degeneration, you can see the progression of myopic degeneration in the posterior pole. In the first year, the hole was closed and it looked nicely opposed, but close to the first year, you can see some inner retinal changes. Those are not cystoid macular edema. Those has been described to about 20-30% of the transplants. They don't need any treatment. They gradually resolve by 2 and 3 years. And now we were very excited when we published initially that the vision was 20/80 in that patient. Now 9 years out, that patient is 20/50 in that eye. And this is her fellow eye. She developed subretinal fluid with fovea cases. Vision dropped to 20/70, and she doesn't want surgery in that eye yet. So the better eye that she's functioning and driving with is 9 years out with the ART. Now I'm going to show you some long-term outcomes too, which are important in many of those cases. This is a patient that failed an ILM peel before, 793 minimum linear diameter, now at 10 months, 2040, and you can see the inner retinal changes that we see close to the 1 year, and now 2.5 years, some of those changes are resolving, and she's still 2040. Her other eye had a very chronic hole, and initially, because of the minimum linear diameter, I did an ILM flap, but it did not close. So I went for an ART, and now she's about 5 months out. She's 20/70, and this is my first bilateral ART case. Now this is another one with a minimum linear diameter 1051. At 2 months it's 20/60, and at 2 years, 2025 with alignment of the neurosensory layer and a nice foveal depression. This is another one with 600 minimum linear diameter, 1 year 2060, 3.5 years now, 2025 with alignment of the neurosensory layer, recovery of the ellipsoid zone and foveal depression. Hawaiian Taban, they worked initially on OCT angiography and fluorescein angiography in cases of ERT, and he showed partial reperfusion in those cases and with fluorescein angiography. Kazawaki Katanusono had a larger series where he showed by OCT angiography reperfusion in 35% of those cases. He also had a large series describing the late morphological changes with 100% closure and 52% significant improvement in vision, especially the ones that had ellipsoid zone recovery. John Thompson and I, 3 years back, wrote an editorial in Ophthalmology mentioning that the challenge over the past decade has been to improve treatment techniques in eyes with macular holes in which the prognosis for successful closure and improved visual acuity is less favorable. And those are the holes that we target with all those procedures nowadays. So this begs the question of what is an atypical hole? What are the holes that we need to consider other procedures to help close those holes? And it seems that the cut is 500 microns, excluding high myopic holes. And this is not addressed in the older classification, which is OCT based. And this is why we had to work on the new classification. And Flavio Resendi was the one leading the effort, and some of us were included in that work to try to amend the classification. And this is what we did. So a large hole is from 400 to 550, X large up to 800, XX large up to 1,000, and giant holes are more than that. And how did we come up with that? Is to review the surgical outcomes of all those cases and the different procedures that were done to try to come up with the classification. And in summary, ILM peel would work in cases up to 500. If it's more than that, you should consider ILM flats. And this works up to 750 and 800. After that, the success rate goes down significantly. And then you should consider those procedures that were looked at in the study, a human amniotic membrane or macular hydrodissection or ART, and those are the ones we looked at. Anatomically, with the amniotic membrane, there was 100% closure, with hydrodissection 83%, and with ART 90%. But the only subgroup that had significant improvement in vision was the ART in the study. Those are the different hypotheses developed over the years for the ART, even before ART, but it's probably a mix of many of those. Now, Kazawaki was working last year about something we call exosomes. And exosomes exist in the human body, they act for healing and transfer of proteins and lipids and so on. And he has been trying to inject in some series IV infusion before and after ART, and he's been getting some good outcomes, and we're going to know more about that in the future. Our paper is going to be published by next week. We considered in some cases where there is myopic holes with significant underlying atrophy, combining amniotic with an ART, and we had decent outcome in 3 cases. One of them is 2050 now, 1 year out. And this is because of the hypothesis that amniotic may help with some cases of geographic atrophy, but we still have to wait and learn more about this technique. Our second global study was in macular telangiectasis, which we know or we thought that closing a macular hole would not help in the outcome of those studies because of the neurovascular disease. And very few cases were reported over the years. That's why the strength of combining our effort as a global study. So we had 30 surgeons with 63 cases, ILM peel, flaps, and ART. And we learned that in those cases, ILM flaps can close 90% of those, unlike 47% only for a peel, although the ILM flap cases had larger holes than the peel. But we also learned that now When you close macular holes secondary to mactal, vision can improve, unlike the common wisdom that we thought it doesn't. ILM flaps should be considered as a primary procedures and ART for refractory cases. Now let's look at different types of ILM flaps developed over the years. This is the retracting door that we published in 2017. And we start at the nasal side close to the disc. You can go for any orientation, but the whole idea here, unlike the ILM inverted flap, you invert the flap over the fovea, but you don't completely relieve the traction around the edges of the hole, which is very important for myopic holes with increased traction. So we peel all the way to the temporal side, and then you put it back over the fovea. You can use viscoelastic, or usually you don't because you do fluid air exchange close to the disc, and it closes very nicely because it retracts. Now you can do it in any orientation you want, but usually temporal hinge would work better. Why? Because when you peel the ILM all the way to the temporal side, the flap will retract temporally, while we know that the retina under the effect of the gas bubble moves nasally. So you have a bigger success rate in closing larger holes, and this is the basis of this. Hiroko Terasaki showed by OCT and geography. To your left on the white is before macular hole closure, and then on the red after closure. When you overlap them, it moves to the left. That means the temporal retina moves nasally and the flap moves temporally, so you can close those holes. What about if you have a significant epiretinal membrane with negative staining with a large hole? Then if you peel the epiretinal membrane, usually ILM is very adherent, you don't have any ILM left to be able to close those holes. So what we published 2 years back is that you use the epiretinal membrane to close the hole. And you can see here, we really underestimate the effect of an epiretinal membrane on the OCT beforehand, and this is why you do the staining. And if you get the surprise that there is a large membrane, you really have to peel it, leave it connected. If you don't have enough ILM for a flap, just put it back in place to close the hole. OCT is very important. We cannot just look at a hole and say, oh, I can close this with an ILM peel. Look at those holes. Those holes are exactly the same. But when you measure, you see exactly the same measurement between the pixelation and the actual size. You really have to measure holes. And when we measure holes, we found that, oh, there could be inaccurate even measurement of the holes. How is that? In high myopes, all our OCT machines are built for an axial length of 24. But if we do the conversion, you have to measure the axial length, multiply by the measured hole and divide by 24. Then you get the actual size of the hole. And you can see in the table to your left how we can really underestimate the size of those holes. It's a linear relationship, and the larger the size of the hole, the more we underestimate the size of the hole. What is the significance of this? Over the years, myopic studies showed that there is less chances of closing a myopic hole, probably also beside the surgical challenges that we underestimate the size of that hole. But when you look at the new classification and you apply it to the graph to the right, you will see that if you have an accurate measurement, you will jump to a different size hole, then your procedure of choice will change. And this is how we can approach myopic holes. And this is the basis of our third global studies, and many of you are in this study. We have 57 global sites. We include axial lens and myopic holes more than 400, and we expect about more than 1,000 cases so far, and we'll do the analysis soon. So I'm going to end up with my personal algorithm again. There are so many options for those holes, but you have to choose the procedure of choice for each. You can only do postprandial vitrectomy for some. You can do peels. You can do different types of ILM flaps. ART when it goes more than 700 or 750. Alport syndrome, you have to go for an ART because of the deficiency of collagen type 4. ILM doesn't work for those. MAC10, we did the global study, and hopefully we're going to learn more about myopic holes from the global study and the collective efforts of all of us. Thank you.
Thank you, Dr. Tamer, for this great lecture. Just want to ask you a question, maybe in the brain of many of the audience. What is the roadmap, a simple roadmap for the surgeon? For example, idiopathic macular hole less than 500 micron, do and do and do. Over 500, over 1,000. Myopic macular, just in few minutes, a short message to every surgeon here. In your opinion.
Well, can we go back to the slides, please? A different algorithm. This is what worked for me over the years, but the message here is that we all try different things, but now through the global studies, and more studies, now we are starting to have an algorithm we go for. I think in the old days, like 5, 6, or even 8 years back, we would say, why don't we just do an ILM peel and see? But if you do an ILM peel in some atypical holes, you already lost the ILM. Some would say for a very large donor sample microns, why don't you an ILM flap initially? But if it doesn't close and you already have a smaller hole, then you lost your chance with an ART. And this is what we're going to know.
Goes to the underestimation of the size of the hole, as you said.
So there are two factors. One of them that we underestimate the size of the hole on ILM period when it's actually 800 or 700, then that's not going to work. The second is some of the very high myopic ones, especially with the staphyloma, the surgical challenges during the case, making sure that there is no vitreous cases. We completely remove the hyaloid, the traction, and so on. Those are some of the differences.
Thank you, Dr. Mahmoud. Thank you so much for this lecture.